Good evening, everybody. For those who don't know, my name is Rianne, and I am Chair of Agile for maybe about an hour more. Welcome this evening to our webinar and AGM. We'll follow the webinar with our AGM. And as we've got a few things to get through, we'll get started right away. So apologies, first of all, we had a change, last minute change in talk and speaker. But we are joined this evening by the wonderful Nima, who is one of our Falls and Bone Health officers. And Nima is going to be talking to us about osteoporosis. And we'll have a section at the end for questions and things like that. And then we'll be moving swiftly on to our AGM, where we say goodbye to a few people and we welcome some new faces as well. So we will get into all of that when the time comes. Going back to Nima, as I said, she's one of our Falls and Bone Health officers. She's going to intro herself and get into the topic, so I won't do any more, but I will be sharing her slides. So please do engage. Please do add comments in the chat, ask questions at the end. And also as a nice intro and welcome, if you can, please just type where you're from, where in the country you're from, and maybe a little bit about yourself and your, professional area. So I will hand over to you, Nima, and I will share my slides. Okay. If someone can let me know when you can see my slides or see the slides.
Yes.
Yep. Can
I
you
can
see
see
them?
them.
Can you see them full screen?
Yes.
Okay.
No.
No, not full screen. Okay.
No.
Let me just let me disconnect the second screen and that might fix the issue. Okay.
Hi, everyone. I think I'll just kind of get started while Rian is getting the slides up.
Can you see them now?
Yes.
Yeah.
Yeah, full screen?
Yes.
Amazing.
Well done.
So everyone can hear me okay?
Yes, we can hear you, Nima. Thank you.
Okay, that's good. Hi, everyone. This is Nima. I am one of the Falls and Bone Health officers of Agile. I also lead a program called Better Bones, and one of its pathways is osteoporosis at the Kingston Public Health. Now, as Rian mentioned, it's a quick, sudden talk, so it's going to be a quick refresher. I think I did this talk sometime 3-4 years ago in terms of osteoporosis. So we are literally going to do a whistle stop. Rian, can I ask you to go to the next slide, please?
Sorry, my mouse is now not working. Let me do down here. There we go. Sorry.
Okay. So it is going to be a whistle stop. We are going to spend some time talking about the risk factors, diagnosis, but also looking at the treatment and lifestyle factors. So very quick facts, but if you need further questions, you can contact me through the Falls email, but also you can contact the Royal Osteoporosis Society as well. Next slide, please. I forgot to mention, you can always put in the questions in the chat as well. Ryan, if you want to kind of just click everything that goes in the slide in one go, no, that just makes life easier for you. Sorry, I was supposed to be clicking the slides, but my laptop is not talking to Zoom today. So when we're like talking to clients, I always talk about, I don't talk about osteoclast or osteoblasts, but I do tell them there are two cells that are constantly building as well as destroying your bone cells. So this kind of makes it a tissue that's always living. So we need the right exercise and nutrition for your bones to keep healthy and to protect it from diseases. So I use this as a way of kind of telling people, no matter how old you are, what your situation is, what kind of health conditions you got, you're always going to get new bones, as well as you're going to keep losing bones as well. So this is a good way to kind of get it. The more we have the good environment for your bones to produce more bone cells than what we are losing, that's going to help us with osteoporosis. Next slide, please. Yeah. So when we think about our bones, again, we kind of talk about, because I do these talks for people, it might be a children's center towards to the elderly groups in our borough. So we think about like saying the bones are growing in length until about age 16 to 18. So this is when the kids are shooting in height. It takes about 2 years for your whole knee skeleton to renew itself in that age group. Until our late 20s, now the bone is not growing in length anymore, but it is getting heavier, denser. So you're getting the internal formation much solid at this stage. Now, at this stage, for you to get a whole knee skeleton from your toes to your skull to rebuild itself, it takes 7 to 10 years. So something that only took 2 years as a child is already taking 10 years even before you hit your 30s. So things have started to slow down even before we start to get into our 30s. What we normally say is until about 30 years of age, we are building more bones than what we are losing. Okay, so that's a good thing. Going on to the next slide, please. And the next one as well. So roughly around about 35 onwards, we actually start to lose more bones than what we are producing. We are still producing new bones, but we are just losing more than what we are producing. Now, the term osteoporosis doesn't come when you're 35. Depending on your risk factors, you might be diagnosed. I mean, you can be diagnosed when you're 17 or 15 as well with osteoporosis. So it all depends on the other risk factors as well. But you can be diagnosed in your 50s, 60s, 70s, or 80s, depending on when your bones are too weak that it's so easy to fracture, but just doing your general movements, your everyday activities. So nothing too major to it. Next slide, please. So if we just again put everything together, this is going to be quite fun seeing it in these tiny little things. So again, I literally put in, it's quite a lot in here, but I just put them because if you're ever looking for fact and figures, the best place to look out for is National Osteoporosis Guidelines Group. And they did a guideline over in 2024. You have the NICE guidelines. You also have the Royal Osteoporosis Society for facts and figures if you're kind of doing any business case or anything for things. In adults, 1 in 2 women and 1 in 5 men will sustain 1 or more fragility fractures in their lifetime. So we are talking about fragility fractures, not any other fractures. In UK, it's about 549,000 knee fragility fractures occur each year. And again, about 105,000 is for the hip, 86,000 for the vertebral fractures, and other structures, about 358,000. Now, we obviously know that not all the vertebral fractures are diagnosed. So we need to question that as well into that. 33% of these were actually sustained by men. And again, men get left out of osteoporosis quite regularly. So it's really kind of important to understand there's quite a portion of men getting fractures as well as having osteoporosis as well. And again, you can think about the pain, the disability, the reduction of the quality of life, all following these fractures through. Now, when we talk about disability adjusted life years, it's about 579.72 days. So when you think about it, this is almost comparable to the days lost from dementia. And when you think about all the advertisement and all the knowledge awareness campaigns that goes for dementia, but not enough for osteoporosis, we do have to question this as well. Now, the next one is about the cost. I'm not going to talk about it, but you can imagine how much is cost for the NHS. We haven't included all the other costs, the economic costs, the societal costs that's happening when people can't actually get back to their previous way of life after a fracture. So we are kind of like thinking, yes, this is for the NHS, but there's far more cost that's not actually added to this cost as well. Thank you, India. Next slide, please. Okay, this is going to be a bit tricky. I was supposed to go one by one. That's all right. It's okay. It's okay. It's going to be hard. Just put all it together. I'll bring it in. So who is at risk? I was supposed to ask you guys this question, but since I can't see you on here, I'm just going to rush through them through. Anyone. We think about people's lifestyle before 30s. I said, you can be 15 and 17 and getting osteoporosis diagnosis. So when you think like that, your lifestyle before 30, when we are making more bones than what you're losing is really important because your foundation is going to be much better or solid if we had a good nutrition and lifestyle before you hit your 30s compared to someone who didn't have the same. Now, some people are more at risk. We know older people over 65 can't actually absorb the vitamin D as easily from the sunlight. Young children nowadays are not getting enough vitamin D, so we don't know what risk they are going to be at later on as they develop into adults, older adults. Pregnant women and breastfeeding women are more at risk of lacking in vitamin D. And obviously, there is osteoporosis associated with pregnancy that can be diagnosed with certain women who might have had a few fractures. And again, I normally spend time explaining what this process is, but I'm not going to. I'm just going to carry on. In terms of calcium, you're looking at people who don't have enough calcium in their diet, but also it could be they're not absorbing the calcium that they are having. So they might have some ulcers, Crohn's disease, irritable bowel syndrome, or they might be taking some medications that actually interferes with calcium absorption. Kidney problems, liver problems might be a reason why the calcium is not absorbed as much. It could also be that they are drinking too much alcohol or actually smoking, which again interferes with your calcium absorption. So we can't just think about, yes, let's just give you lots and lots of dairy products, but it's about saying it should actually going into their bones. Are they having enough vitamin D to help the calcium get into their bones? So talking about that, the next part is the vitamin D deficiency. So just being in this country, we just don't get enough sunlight. That's a full stop question there. But it could be that you have liver problems that's stopping you from converting the vitamin D to the right level for it to work with your bones. Again, it could be some medications. If you're smoking, drinking too much alcohol, that interferes with your vitamin D deficiency. You might have some skin conditions or at risk of skin cancers, and we're told never to be out in the sunlight. You might actually have some cultural or individual preferences where you are covered whenever you go out. You might be more of someone who's at risk of getting infections quite slowly and they are covered up for different reasons. So, different reasons, but if someone is not getting enough vitamin D, they are going to be absolutely at risk of osteoporosis through. The next part is whoever is being inactive or being bedbound. Again, you're thinking about saying someone who ended up in the hospital, and we have done enough in terms of how likely it is for someone to actually lose their muscle strength, lose their balance. They are losing their bones as well. It's not just the muscles and the bones that balance that you notice, because we notice those. The bones we don't notice. So when they do come out and they have a trip at their home, then if they do end up falling, they might be more likely to have a fracture. Saying that, it could be the health conditions that's stopping these people being inactive. They might have had a stroke and therefore they're not weight bearing on one side as much as they do on the other side. Or there are conditions like Parkinson's or different conditions might reduce them being active and being mobile. So anything you're thinking about where people are not actually, sorry, I'm just trying to do this, not actually being as active, putting the weight through the bones are going to be at risk. Now, I talked about calcium and vitamin D, but we need to think about the whole balanced diet. Celiac people are more at risk of osteoporosis. Again, you're thinking celiac is nothing to do with your calcium or vitamin D, but we need the full balanced diet. Anything that's going to affect the metabolism is going to have an impact on osteoporosis, on the bone health. So again, we might think about like diabetes type 1, and the restrictions might actually add up to this. Now, we might also think about other conditions, anything that's going to stop you from absorbing the nutrients. So anything to do with your small intestine, you're thinking about irritable bowel syndrome, Crohn's, ulcers, conditions like those. But it could be that someone, again, a lot of diets go without enough fat, and we know vitamin D is fat soluble. So we need to think about the full balanced diet, and there is more and more evidence coming in terms of fibers and osteoporosis, your gut health and osteoporosis. So again, we don't know where this ends, but we are looking at full balanced diet there. And the next conditions we are talking about is the health conditions. The first one that most of you will probably remember is rheumatoid arthritis, the nature of the condition itself, but also the medications used for these. A lot of cancer treatments do end up affecting the sex hormone levels, which interferes with your bone health. In terms of other conditions, any health condition that's going to end up in you taking steroids as tablets, if you're taking steroids of 2.5 milligrams for 3 months or more, you should really be looking at your bones at the time. Now, again, it might be you're absolutely fine. Your bones are fine, which is great, but someone has to kind of do that review to make sure that it's not having an impact on your bones. Now, you might think about like people with COPD, asthma, different things where they might just have the inhalers, which is fine. It doesn't have the same evidence as oral steroids. but they might end up taking oral steroids every now and then when they get the flare-up. Again, it depends on how often they end up with the flare-up, how often do they end up with the steroids that we need to keep an eye. And also we need to keep an eye on if they have other risk factors that might be the reason behind it. In terms of health conditions, I think the FRAC score nowadays, it includes Parkinson's disease as one of the health conditions, even diabetes type 2, type 1. So it's all kind of being added in terms of bones. But also you might think about any kidney or liver problems, again, going back to how the calcium and vitamin D are kind of converted and being added to us as well. I miss the whole eating disorders pathway, which is absolutely huge. And especially if it happens to be a girl, a woman who kind of missed her periods, then you can kind of like definitely think about their bones as well at the time. Now, mental health conditions, a lot of medications used, not all of them, especially the old ones seems to be the ones that are more at risk in terms of these. So again, yeah, kind of like thinking about different mental health conditions, how these people are more at risk of osteoporosis as well. So being aware of those as well. I think there's a few more in this slide. I think we all know about the menopause. Women tend to lose 50% of the bone loss happens in the first 10 years of menopause. So it's really important at that age to kind of think, I mean, this is not just menopause, it had to be like perimenopause, premenopause, menopause, the whole process of it, about 10 years or so. So we need to kind of think about, increasing their calcium levels, their vitamin D, their exercises, how to kind of manage the loss of estrogen while they're going through this process. Some mention about the sex hormone levels. So we talked about the cancer treatments, we talked about the menopause, but any surgeries or anything that kind of alters sex hormone levels in both men and women will have an impact on the bones. And that goes for the growth hormones as well. Anything that affects the growth hormones, anything that affects the metabolism is going to have an impact. I think medication, I talked about the steroids and the cancer treatments, but when you think about some of the anti-epileptic drugs, not all of them, some of the antidepressants, again, we are looking at some of the blood thinners, some of the diabetic medication. So you're kind of like looking at a little bit more than everything. So again, kind of like looking at what medications someone is having. It might be a medication that kind of lines the tummy up and therefore kind of interferes with the absorption of the nutrients as well. So we need to look at a full balanced diet, and is it being absorbed? And is there any of these medications that are altering or interfering with these as well? Next one, please, Rian. I don't know whether there's any more on this. Okay, just put everything in. So when we think about, in general, we always think about the age in women over 50, men over 70, if they don't have any other risk factors, just because this is where the hormonal changes kind of happen, the sex hormone changes. Obviously, women tend to have it more than men, but it is 1 in 2 women to 1 in 5 men. So it's still quite a high number, even men as well. And Caucasians and Asians are more likely, just because in terms of genetics of our bones, but also in terms of our skin, getting the vitamin D as easily. Smokers tend to have more risk. It interferes with their calcium, vitamin D absorptions, but also changes some of the hormone levels. They also found people who are smoking tend to have early menopause and more hip fractures than the ones who actually have stopped smoking. So that's something to think about as well. We definitely have a family history. And when you think about if your mom or dad had a hip fracture, they are going to be far more at risk. And it could be the family history of early menopause happening through. It could be family history of rheumatoid arthritis or being celiac. So again, there's so many factors in terms of family history that comes through. The next part is the bone structure. So no matter whether you're a man or a woman or which background you're coming from, if you have weak bone structure, and this is unfortunately going back to your genetics, doesn't really help. Body weight, people who are underweight are more at risk of osteoporosis. So even though I said that, there is a portion of people who are overweight and getting osteoporosis. And this goes back to malnourishment. But also it seems the vitamin D is not easily absorbed by people who are overweight. So, that's, even though it's a condition that we normally kind of think about being underweight associated, but there is a portion who can actually be overweight and osteoporotic at the same time. In terms of alcohol, again, the changes in the hormone levels, but also absorption of calcium and vitamin D doesn't help with that. But also, if your bones are weak and if you're a bit drunk and your balance is not that great, it's more likely to have a fall and fracture at that time as well. Next one, please, Ria. So how do we diagnose that? The ultimate one is the DEXA scan. Again, there's so much new versions of them coming out, which is great, but I don't know how much are actually available in NHS as such. But normally in a DEXA scan, you're looking for a T-score on the left hip and the lumbar areas. So what they're looking at is finding how much your bone mineral density is and comparing it to a reference range, which they've taken from young, healthy adults and how much they've lost for your gender and age guys. So that's how they can. And what's the difference between yours to the normal loss of your bones? So they're checking those two. Now, if yours comes as a 0 to -1, that's a normal loss. So that's how much is expected for your gender and your age to be losing, which is great. Now, if it comes as -1 to -2.5, it will be osteopenia. So this is not the stage where it's normal, but it's losing a lot more than what it should, but it's not as bad as when you have osteoporosis. And I have known people who literally kind of can improve themselves from exercise and diet and a good lifestyle factors going into the normal range from osteopenia. Again, you're looking at other risk factors as well. So it's not just kind of making sure that you're trying to eliminate as much risk factors as possible when they do that. When it comes to osteoporotic stage, it might be a little bit different. The further up they are, there will be a need for medication. And I know a lot of people are reluctant to take the medications, but part of my job role will be like convincing people or trying to kind of tell them what's the advantage of taking medications to not. But there are so many new drugs that are coming up, which are actually helping through. Now, DEXA scan, you can have them done at least every 2 years. So not before that, because you won't be able to see much difference if you do it before that. Next one, please. Yeah. So what other things can you do if I have to wait for 2 years to see how much are we losing or what's there? The nice guideline is we don't really need a DEXA scan to say whether someone needs a treatment or even to start a treatment for osteoporosis. Because DEXA scan, all it says is, yes, your bone mineral density is low. Someone can have low bone mineral density, but carry on absolutely fine without any fractures or any impacts on their life. So we need to kind of look a little bit more into the picture rather than just the bone mineral density. So this is where the scores like FRAX score or Q factor comes in. Again, the FRAX score is used a bit widely just because you can add the DEXA scan T-scores into the FRAX score to give a much accurate reading later on as well. And it also is a little bit shorter and quicker as such. In terms of the FRAX score, they've added the new line to say whether you need to think about treatment. So it's very clear as saying, okay, this is the low range, you're fine at this range. This is a phase where you need to think about whether you need some assessments, some identifications. And this is a place where you need to start treating. You don't need any scans or anything. You just have to start treating because you've gone above this threshold. Obviously, there's different conditions. It is, if you go into the FRAX website, it is free. It's done through Sheffield University, so you can literally go in and put in the details. It's done for anyone from 40 to 90. And then obviously there's a cutoff range for the weight as well on that. But if you actually go in, put the details of all the secondary clinical factors you're thinking about, it should come up with a graph that tells you where to start as well as the scores. There are some adjustments you can do if someone has a few more than one fracture or they've got diabetes or Parkinson's, different things like that. What they have done is when you go down that page, you can actually see what other things you can do to the score to make it more accurate for the client that you're seeing. But if you actually are able to pay, then you can get the FRAX Plus, which actually does everything for you. So you don't have to do anything. You can put in and it will do all the scoring and come up with the accurate results there. Going on to the next slide, please. Yeah. So again, quick one. So we're thinking about how do we keep our bones strong, or how do we let our clients to keep their bones strong? It's looking at their diet, exercise, lifestyle factors, and medications. So if you can go to the next page, Rian. So when you think about the diet with bones, we are looking at the full balanced diet. As I mentioned, it's actually even celiac people who we are thinking that's gluten-free, they are more at risk of osteoporosis. So if someone is missing a food group for whatever reason, they are going to be more risk in terms of their bones. So we need to think about how are they going to manage to get the nutrition that they need when they are avoiding a particular food group, or when their body can't absorb the food group, or they were told they shouldn't be having this group. So again, going back in this, if you look at the British Dietetic Association for these details, so it might be someone with celiac can go in that website and look for the leaflet to say, what do I need to do, or how can I kind of protect myself from celiac? And that comes up. On the other hand, it might be someone who doesn't have enough iron in their body. So again, going in there to see how they can kind of help themselves in terms of managing to have more iron-rich food, or how to look out for those, or someone who's vegan looking for the alternatives. It's quite a good website to kind of go in and get those leaflets, which you can easily give to your clients as well. Now, when you look at the full Eat Well plate, there's a small portion there on fat. And I tell people even fat becomes important with osteoporosis because vitamin D is fat soluble. So you having the vitamin D with the fat is going to help it absorb better. Also, what it does is when you're if you're a woman or a menopause stage, the body fat actually produces some estrogen, which again helps you with your bones. So it's not kind of like looking through, and also talking to people about their carbohydrate, fiber-rich diet, so they don't kind of like completely look them. It's looking for the right fiber and right carbohydrate rather than avoiding them. So it's looking onto those. Going into the next page, Ria. So I put the Eat Well plate to kind of say, in terms of bones, even though there are so many studies that I'm going to talk about calcium, vitamin D, but no matter what it is, or there are so many other nutrients like zinc, vitamin K, there's so much things that actually helps with your bones. But the conclusion is, if we eat a full balanced diet, take vitamin D supplement, and making sure you got enough calcium in your diet, you don't really need extra supplements for your bones, as long as your body is not absorbing or some other things are going on. So it's a good way to kind of tell people, have a full balanced diet, make sure you're taking your vitamin D supplements, and keep an eye on your calcium. How much are you having? So calcium, you should be taking 700 milligrams for adults. For people who are at risk, or postmenopause, or other risk factors, they will be asked to take up to 1,000 milligrams. Now, with the calcium, we advise people to take it through their diet rather than actually having it as medication. So again, we always advise people, don't go and just buy them over the counter. Take it through the food, because your body tends to absorb what it needs and the rest comes out. But even saying that, it might be for someone with stage 3, stage 4 kidney failures, and or even certain heart conditions. They might actually advise them even to reduce the dietary calcium. So we need to be careful with the calcium in terms of like not overdoing with calcium through. Now, on the other hand, sometimes people prescribe calcium because they need to have enough calcium in their bloodstream, in their body, for the medications of osteoporosis to work. So for whatever reason, if they can't eat enough calcium, or if they're not absorbing them, then there will be a prescription of calcium to make sure that they are having enough calcium for the osteoporotic medications to work. Vitamin D is 10 microgram for everyone over 12 in this country. And this is quite a low level. When you look at other countries, they are much higher dosage. Even here, if you're like an athlete and stuff, you might be taking 80 to 100 micrograms per day, or even more. So in terms of overdosing, is quite a least amount. If someone is at risk, we might be asking them to take 20 to 25 micrograms per day. Now, vitamin D is one thing which needs to be taken as supplement, unless you're out in the sun and getting all the sunlight without your sun lotions, because that interferes with your vitamin D absorption. So it's really hard to kind of get it through your diet. So either it's a sun or it's a supplementation. So when people say, oh, you know what, I really don't want to take any medication, then you must at least take them over the autumn and winter months, especially if these are people who are at risk or who already have osteoporosis, in which case they definitely will need the supplementation to actually have them. As I mentioned before, it is fat soluble, so eating it with some fat content will actually help it to be absorbed better as well. Now, vitamin D, I know it comes from the sheep, and again, people kind of like go like, oh, but I'm vegan, or I don't want to touch anything to do with animal. You can have the vitamin D2 versions rather than the D3, which comes from the sheep. So you could kind of like go on that. And calcium has the same thing as well. There are a couple of different formats of calcium. So if someone can't take the prescribed calcium, they can go back and get a different format that they can chew, or, there is different forms. Sometimes people find it hard to swallow, but there are different options for people to do it as well. So if they are prescribed, they should be taking them. Next one, please. So exercise part, we are going to go. So I'm just kind of like going with the Royal Osteoporosis Society guideline that came with saying like strong, steady, and straight. 3 S's to remember for osteoporosis. If you go to the next one, please, Rian. Okay, that's the slide with the whole lot, but we are going to go to the slide after this. Okay, so this one, I'm really sorry, but I'll have to kind of read through this very tiny mobile phone thing through. But so the first S is to do with the strength strong. So you're looking at the muscle strength as well as the bone strength. So weight bearing exercises and impact exercises. So anything you're doing upright is going to be weight bearing, sports, dance, housework, doesn't matter. Impacts, there's so much evidence in terms of 50 impacts. I know it says most days in the guideline. I tell people every day, 50 impacts a day, make it your mantra to kind of work on your bones as an important thing. The main thing to remember is while they're doing that, they do have good shoes on. And if they are prone to other arthritic conditions or joint problems where we tell people to avoid or lessen the impact, it's finding the balance between their bones and the joints to do that. The next part about the muscle strength is to 2 to 3 days per week of muscle strength. And again, it's about 30 minutes we're thinking about. It could be any activity with your own body weight, with some dumbbells, with some resistance bands. It could be carrying stuff. So a huge amount of variations in terms of what they can do. Now, here comes the question of what if they just had the fracture there? So it's again going back to the basics. You start low and gradually build up. You don't start people at the high impact or moderate impact. It might be for some people, it might just going into the low impact. That's where they stay. So it's individual in terms of how do you where do you start and how much you progress someone to as well. Next page, please. Next slide. Thank you. The next one is steady, which shows for the balance again is 2 to 3 days per week. And we are looking at any balance activities, balance exercises at home, group classes, Tai Chi, dance, all those are going to kind of add in terms of balance work. Again, people who have better balance, even though their bones might be quite weak, they may never have a fall or fracture because of that. Next one, please. And the last one is straight. Again, it kind of talks about daily. I say like this is all the time. We need to think about your posture. You might be working on specific exercises as stretches or to strengthen your core muscles, your back muscles. It's also looking at how you put your weight through. How are you walking your posture when you're walking, you're sitting, you're lying positions, but also thinking about how you carry, how you lift, how you safeguard. Again, it also talk about a couple of things in terms of being cautious apart, never saying we can't do them. It's just being cautious in terms of like flexion or sustained flexion, especially if we are doing them with the weights as well. But again, it's just kind of like individual basis on how you start and gradually progress as well. Next slide, please. I think if you can put everything up together, yeah, thank you. So in terms of medications, again, there's quite a bit. It all depends on are you a man or a woman? When did you have your osteoporosis? Are you over 50? In women especially, is there another reason? So for example, parathyroid hormone, if that's high or if is your thyroid high, and is that why you got osteoporosis in the first place? So it might be looking at the other reasons for it. So depending on why someone has it or where they have got it, sometimes they might just have it in their hip. The medications can be managed depending on individual persons. Now, the main starting one that you might have is, again, calcium only if you're not eating or absorbing enough calcium. That's when it's prescribed. Vitamin D, again, most of the UK should be taking it. So most of the time it's not prescribed, it's been asked by the clients to buy it themselves. It might actually go into HRT if they had an early menopause, and they can go up to 60 years. And especially if they have like symptoms that are not just, you're not just thinking about the bones, but you're also thinking about the menopausal symptoms as well too. For people who, again, HRT has its own risk factors. So for people who might not be able to take HRT, it might be estrogen receptor models. And it could be other medications, which they might just take depending on the condition. So if it's parathyroid, it might be specific to each condition that you are kind of managing as well. When it comes to osteoporotic medications, the first line of medications for the bones is your bisphosphonates. You're looking at alendronic acid, isoniazid. Normally, it's alendronic acid that's given, and it's kind of like given for once a week for up to 5 years without the review. So they need to have a review at least every 5 years to see if they still need it. They might still need it, or they may not, but it is kind of like making sure that these people are having a review there. And the other part of it, that people are taking it correctly. They are kind of having with huge amount of water, not bending down straight after. So it's kind of like, keeping themselves upright, just to kind of avoid some of the side effects that's come through as well, and letting their dentist know that they are on these treatments, or let them know before they start the treatments to have any dental work done. Now, these are the ones that kind of like delays the reabsorption of the bones, while the other part of the next set of medications is anabolic, so they are help up with the build-up of the bone cells. Now, again, there's quite a few options there, but each one has its limit in terms of teriparatide. You can have it for up to 24 months. So you're kind of looking at each one. And when it comes to these decisions, it kind of like these ones normally go to the consultants. The bisphosphonates, your GPs are able to do it normally, and that's your first line of medications, unless they think this person had a fracture while they're on bisphosphonates, or they are a much younger person, or they have other reasons why they got osteoporosis. Then they might be sent to the consultants to ensure that they get the right medication at the right time, because each one has their time period, and also it might be thinking about what do they need to have afterwards, because if they continue on the ones with anabolic and it stops, the bone density drops very quickly. They lose the bones very quickly. So they need to make sure they have a plan for them to carry on after this medication stops to the next one as well. So there is quite a few options. Again, no guidelines is great. If you look at them, it kind of talks about each one specifically and how long and what are indications and contraindications for each one of them as well. Next one, please. We might be finishing. The last but not the least, I don't think I've got another slide. I think I might just finish with that. Is remembering about the smoking and the alcohol. In terms of like people who are stopped smoking still seem to gain benefits, even though they smoked 10 years before for 20 years or so. In terms of like people who are smoking, it's always advisable to say if they can quit. In terms of alcohol, you're thinking about reducing the amount of alcohol that people are having per week, and kind of like, especially the more risk factors they have, then it becomes more important to kind of reduce the number of units that they have per week as well. Next one, please. Okay, I think so. In this quick ones, we are thinking about 15 packs a day, muscle strength and balance exercise 2 to 3 times per week, vitamin D supplementation, calcium from dietary sources. But if they have been prescribed or recommended calcium, then they should be taking those, as well as the vitamin D supplements. Next one, please. I think there might be one more too. Again, making sure that people are maintaining a healthy weight, but also following a healthy, balanced diet as well. And the next slide, please. So again, Royal Osteoporosis Society is great in terms of anything to do with osteoporosis, their medications, the risk factors, also some videos of exercises that you can kind of use that. British Dietetic Association, anything in terms of diet, if you're going through menopause, what kind of things to look out for in terms of diet and menopause, etc. No guidelines, I mentioned enough during the talk, I think. We can always contact us for further information as well. Thank you. And thank you for listening. I can't see any of you.
I'll stop sharing. Thank you so much, Nima. That was very, very interesting. Any questions for Nima? Feel free to unmute, put it in the chat, raise your hand, physical or virtual. I have a question that I can ask you, Nima. So it was about the recommendation slide you had there near the end when you were saying about the different recommendations for improving bone health. And from my perspective as an inpatient physio, I work in trauma and orthopedics, so I'm seeing people quite acutely, day 0 to day 10 after a hip fracture, for example. We struggle with those type of recommendations in the acute phase. Are there anything specific beyond the medication which the doctors do from day 5? But is there anything specific in an inpatient or acute setting that you could or you would recommend?
I think definitely I would recommend in terms of weight bearing activities. Yes, they may not be able to do the impact, but weight bearing, because again, you're thinking about after a hip fracture, the longer they stay in bed, their weight bearing is going to go, and their bone strength is definitely, they're going to keep losing their bones. So I think it kind of goes back to all the PGA paralysis or the deconditioning we talk about, but we kind of always talk about in terms of muscles and how their functional abilities and stuff. But we need to start thinking about the bones as well. So I would definitely think about weight bearing activities. The other part I would think about is good nutrition. Yes, they do get the medication on, especially after the hip fracture. But if the calcium is not prescribed, because again, I think most of the time when they get to the hip fracture, they might have been prescribed calcium as well, just to kind of like a way of making sure that the calcium is in their body. But the rest of the full balanced diet does come in very early on, because there might be someone who's not eating well enough, and some of the conditions like Parkinson's and COPD or dementia, where people are not eating well, and you're kind of thinking those people are at risk of more hip fractures, more being underweight. So it kind of goes together with all the factors as well. So it's the basic, and again, if they're smoking, and if they're kind of, and we know more smokers tend to have more hip fractures, so that's another way of kind of like telling people. I mean, they might go, I already had one, so what's the point now? But it is kind of getting with the smoking and drinking as well to actually think about. And obviously, I didn't talk about the drugs and everything, so keeping a healthy lifestyle.
Yeah, thank you. Just one question in the chat from Joanna. She's asked, do you have any falls program you recommend?
I mean, in terms of falls, later life training, PSI, is obviously they're kind of enough evidence based and gone through. And it's a good one that you can train the instructors, so they are in good programs and they go from like getting up from the floor to everything. And they definitely have a bone health component onto it as well. So I'll do that. The other ones, I don't know if they still do, the APPI, the Australian Physio Pilates Institute, or the other way around, Pilates Physio, whatever. They used to do like Pilates and bone health courses as well, which again is kind of like it's going onto the Pilates space, but it's quite a good one in terms of encouraging people bone health to go through. So those are the two I could think of straight away.
Amazing, thank you so much. Any other questions for Nima? No? Okay, we'll leave it there. Thank you so much again, Nima. That was a great presentation. Hopefully everyone got a snippet or something they can take away and take into their own practice, research, and into their professional experience.